So thank you everyone for joining what is the ultimate session in this year's South Asia Symposium organized by the University of Hawaii at Manoa. I'm very pleased to have three excellent papers here. I'm the moderator for this session. My name is Ashok Das, and I am an associate professor here in the Department of Urban and Regional Planning. And so we have three presenters. We'll just go as per the order on the schedule. And so we'll begin with Shahana Munazier from University of Wisconsin-Madison, and her paper is titled Strategies of Care, Politics of Gharelu Muslim Women in India. So you have, so we'll give each presenter 20 minutes. So I'll give you a 5-minute warning in case you are able to look at your chat window. And then again, a 1-minute warning. Okay, thank you.
I was actually under the impression that we were presenting for 10 minutes and then there was the question answer session after 10. So I actually decided to, I realized much later during this time that,
Yeah, no, we are going to take all the questions mostly at the end. But if there is any pressing clarification question, then that could come immediately after the presentation. Otherwise, all substantive questions could come all together at the end. Yeah, thank you.
So, yeah, I'm not going to take 20 minutes, but anyway. My project title shifted a little bit. It's called, it's more or less the same, but it's called Strategies of Care, Gharelu Muslim Women in India in Times of COVID and Beyond, because I realized that that was a session title as well. And there's few overlaps with COVID, but mostly this project has started much before COVID, so it's going to continue. But I'm sure COVID has impacted in a way that would be interesting for our audience today. So I'm going to talk about a little bit about how I have sort of come to this project and where it's taking. I'm a graduate student in my third year at UW-Madison in anthropology. And so I'm starting off with this project. So the idea is to sort of test some of these ideas with the South Asian audience to see where it goes, and hopefully get some interesting comments and questions eventually. So I'm going to start with an ethnographic vignette with one of my interlocutors. I anonymize her as Amina. So Amina is a 25-year-old Muslim woman, lives in an impoverished neighborhood in Patna in the northeastern part of India. In Bihar, she's a high school dropout from an Islamic school. In her everyday, she usually keeps busy with the care of her grandmother and does most of the regular household chores like cooking and cleaning. My association with Amina has been developed since 2016, when I first began my fieldwork to understand the projects of Muslim womanhood through Islamic schooling in India. In that, I explored how a mixed curriculum in these Islamic schools that teach both religious and secular education not only open new career paths for women like Amina, but also that their piety allowed many of these girls to develop a sense of agency, and that this agency was embedded in the capacity of girls to tactfully negotiate through patriarchal expectations. In other words, I noted that even if religion was central in the everyday lives of many of these girls, the collision of competing desires with piety defied a very simple equation between piety and agency. For my current doctoral project, I spoke to Amina in 2020, 3 months into the pandemic. Talking to Amina about her future plans, 4 years after her graduation from the school in 2016, it became evident to me that Amina continues to stay at home. She does the regular household chores and spends most of her time teaching Arabic and Urdu to her little siblings. She told me she did not get admission in any government university, and her parents didn't have enough money to send her to a private college. I remember back in 2016, Amina had said that she wanted to become a teacher. But this project is not about her dashed dreams and aspirations. Rather, it is about thinking through complexities of ethical self-fashioning with the relational others at home, and how many pious people or women like Amina frame their desires through caregiving and religiosity. Staying at home as Gharelu caregivers, Amina felt a strong obligation to stay at home to take care of her family. She said that by caring for intimate others through the practice of Islamic caregiving, Amina can hope to get divine rewards that would better her future. In other words, Amina knew that by caring for others, she was actively taking care of herself. That caught me by surprise, Firstly, her religiously embedded narratives of everyday care actively muddled the pious and the non-pious engagement with ethics, which I had unwittingly reified in my earlier work in my MPhil. Secondly, I figured out that in this moment of the pandemic, many young Islamically educated Muslim women like Amina live in small towns in India, have become caregivers at home, possibly because of lack of employable options and partly due to the Islamic mahal or ethos. Thus, I understood that the idea of modernity and aspiration through which to analyze personhood was acting as a reductive impediment in thinking through complex questions of subjectivities of pious women. Women like Amina use the local term called Gharelu to call themselves stay-at-home everyday caregivers. It is worth mentioning, though, that Amina's decision, or perhaps her inability to pursue, to not being able to get any employment or go to higher education, is of course a reflection of structural problems and Muslim minority insecurities predominant in contemporary India. And it's obviously not a matter of just religiosity. But as I argue in this paper, religiosity in terms of thinking through concerns of caregiving play an important role in how young women frame their narratives of precarious and uncertain social and economic conditions. In other words, they're not simply victims of their situation, but are actively finding ways to negotiate their positionality and create a better future for themselves. To this end, my current project responds to the central research question as to how do young and married Muslim women with Islamic education and are roughly between 20 and 25 years understand the task of everyday care for family members and their positions as staying at home or Gharelu family caregivers. In exploring this central question, my paper argues that firstly, in addition to practical obligation and gender division of labor, which is obviously the case in many of these Muslim households, Islamic caregiving for domestic women in lower middle-class Muslim neighborhood in Patna is an act of strategic bargain with the divine. In this divine bargain, I argue that by caring for others, such as cooking and cleaning and taking care, Gharelu women strategize self-cultivation to take care of themselves. Secondly, this form of Islamic caregiving is generative. That is, it is definitely attentive to women's agency and possible futures. Since India's liberalization in the 1990s, there's a general shift in aspirations of lower middle-class young Muslim women in India towards modernity, often made sense through employment and aspirations of choosing their own marriage partners. However, the elderly, including parents, often also expect single women to cultivate habits of being stay-at-home caregivers as a form of repaying parental debt, as well as to practice future caregiving practice for the arranged marital homes. Thus, being Gharelu is also increasingly considered an important attribute in unmarried women in contemporary India. However, one which has received less attention in anthropological literature on Islam, ethics, and care. My current project responds to this gap by undertaking an ethnographic study within the social milieu of marginalized Muslim households in India. Due to limited opportunities for university education and employment for women with Islamic schooling, particularly in Bihar that has a long history of socioeconomic marginalization, a situation that has been massively aggravated by the current pandemic, young women are forced to stay at home as Gharelu caregivers. In the context of capitalistic modernity, being Gharelu by virtue of staying at home is often associated with passivity or lack of socio-political and financial aspiration. However, my project aims to demonstrate that for many Muslim women, especially in Bihar, being Gharelu is not only a practice, but it's also an attribute. It is an alluring habitus and an ongoing process of self-fashioning, aided by caregiving for intimate others. My pre-dissertation ethnographic work has shown that in many Muslim households in India, everyday caregiving by Gharelu religious women is neither simply an act of sentimental relationality or a disinterested act of service spurred by practical obligation. Rather, Islamically educated female caregivers engage in caregiving by embodying a carefully crafted Islamic care script and filial piety, a script that tells them what to do, how to do, when to do, and practices and performances of care. So in this particular slide, I sort of show two instances of two photographs, and these are all taken from Google Images because I don't have the real ones, but it shows that, you know, Islamic caregiving is actually comes from theology, it comes from the Quran, it comes from the Hadith. And so there's an active sense of how these pious Muslim women think about taking care of their intimate others, their family members. It's like sort of a duty. So that's what an Islamic care script is. And a lot of these schools which have religious teaching, they actually also help women to realize this duty towards caring for others. And so it's an active embodiment of caregiving that happens through religious understanding in schools, and also practice of religiosity at home. So rather, Islamically educated female caregivers engage in caregiving by embodying a carefully crafted Islamic care script and filial piety, a script that tells them what to do, how to do, and when to do in practices and performances of care. Particularly for lower middle class Muslim women, as I was saying, Islamic care script is embodied through their everyday performance of religiosity at home and through the religious teaching in Islamic schools. My project aims to understand how this care script and piety acts as a mode of strategic bargain and a means of self-fashioning for young women that involves both an emotional and practical caring for themselves and others. Within this practice of relational caregiving, Gharelu women's agency is linked with hopes of futuristic divine rewards. These divine rewards are felt strongly in the form of deepening intergenerational kinship ties, form of a deeper companionship with the divine, as well as gaining material rewards of financial security and better marital prospects in the future. Amina, for example, tells me, I am sometimes tired of staying at home. This whole situation of staying at home due to this virus going around makes me think what the purpose of my life is. My parents are searching for a good arranged match for me, and I'm okay with that. I truly believe that even when I'm upset and I'm tired of everyday work, I will be rewarded by Allah in this life and after. In the meantime, my duty is to simply carry on. This idea of carrying on, although seemed quite mundane at the time, is an explicit epithet of yearning for a good life, which Amina aspires for as moral truths that makes demands upon her. And conversely, these projects and these commitments get her a sense of self. Her ethical dilemma of being tired of being at home, taking care of everyone, while at the same time believe in divine rewards for a good life, confronts her not as a universal problem to which an objective normative answer is demanded, but rather as an intimately personal one, bound up with her ongoing commitment to the divine and her efforts to create a good family life. These familial commitments are essential life projects for her. So then why is this project important and why now? And so for my experience of engaging with literature on Muslim women is that the early literature has almost always exclusively devoted to understanding the low education attainment levels of Muslim women. And which is, again, it's an important thing, but I'm trying to move past that sort of literature, and as well as sort of present Muslim women as a group that is collectively oppressed and as victims of the religion and culture. And so in doing so, freedom and agency of Muslim women have often been understood as a matter of resistance against a structure external to the individual. However, the anthropology of ethical self-fashioning, which my project essentially deals with, which is pioneered by Politics of Piety, Saba Mahmood's very critical book, emerged precisely to counter this form of Eurocentric assumptions of Muslim women as victims, to instead focus on Muslim women's agency and freedom beyond the liberal lens of coercion and choice. Echoing a discussion which is predominant within anthropology of ethics, Saba Mahmood and also Charles Hirschkind found inspiration in Foucault's understanding of ethics in that they focus on self-formation in relation to discursive regimes of power. Based on these trends, a recent set of literature on Islamic womanhood in India, including my own MPhil work on Islamic girls, focused on the ethical self-fashioning of a modern Muslim woman with Islamic education. Now, who is this modern Muslim woman? This modern Muslim woman was situated against the backdrop of India's liberalization policies in the 1990s and the process of globalization thereafter. Much of the scholarship on New Age Islamic woman has drawn inspiration from anthropologist Arjun Appadurai's concepts of the capacity to aspire and the future as a cultural fact, to theorize aspiration of Muslim women as almost an a priori ideal of empowerment. Thus, in the last decade, the projects on Islamic womanhood in India have been predominantly focused on the trope of a modern and aspirational Muslim woman who is invested in the self-fashioning of Islamic selves whilst maneuvering modernity. My conversations with Amina and the way that she's dealt with it defies this idea of the modern aspirational woman. Her aspirations do not necessarily talk about like becoming a teacher or a doctor, an engineer, which is quite frankly, a lot of these Muslim women talk about when low middle class Muslim women or women in general sort of speak about. But so that's the kind of question that I'm trying to raise, is that modernity as an association or as an add-on or appendage to Islam necessarily always sort of brings out this idea of empowerment that a lot of women do not necessarily adhere to or are not capable of adhering to. With an excessive focus on the modernizing processes, the scholarship has reduced Islam simply as an add-on to modernity, rather as an ontology in and of itself. More importantly, in doing so, much of this literature on Islamic womanhood continues to reify the binary between religious and ordinary ethics, which I would admit that most of the anthropology of ethics precisely aim to move from, but has found no solid agreement on how. Through my ethnographically informed work on caregiving, I aim to demonstrate how it's not only possible, but important to move away from these binary epistemes dominating Islam and ethics. Particularly anthropologist Cheryl Mattingly's discussion on virtue ethics and ethical self-fashioning is important for my work, in that she points to the ethical turns narrow focus on the self at the cost of under-theorizing how humans are interdependent beings whose very survival actually depends on caring for the self and others. So my current study in Islamic caregiving will highlight how self-fashioning by Gharelu Muslim women firstly brings out these phenomenological approaches to the experience of emotional and practical obligations in caregiving, embedded in diverse affective and often obscured forms of kin ties. These obligations present themselves as forms of moral laboratories, as Sharon Mattingly calls it, that produce the possible as against the probable, that produce singular acts that transform material and social space and create moral selves and are marked with a radical uncertainty. Secondly, it will highlight the role of religiosity and filial piety, particularly concerns of divine rewards in centering these kin ties, strategies, and negotiations in caregiving. Just to conclude, I'm going to say that my ongoing work will expand the understanding of Islamic womanhood, formed simultaneously at the interface of religiosity, care politics, emotions, and future that cross-cuts generations, and that strives to bridge this distinction between ordinary and religious ethics that elide such possibilities and uncertainties. Thank you.
Thank you, Shahana. That was excellent. Does anyone have any clarifying questions at this moment? I can see that I think our third presenter has joined. So maybe we'll have to alter the order, Anna. So we'll go with...
Yes, that's fine. I'm not sure if Dr. Babu is even coming since he's not here yet. So
okay. All
Sarah,
right.
welcome.
Sarah, okay, so let me just formally invite her. So our next presenter is Sarah Ahmed from the Indus Valley School of Art and Architecture in Pakistan.
Just in time. Oh.
Yeah. So from the Indus Valley School of Art and Architecture in Pakistan, and she is going to present on Piety and Polio, how lady health workers employ Islam in polio eradication efforts. So welcome, Sarah, and the floor is all yours. The screen is all yours.
Thank you. Oh, I didn't know I was presenting right away. Wonderful timing. Give me just a second as I set the
Yeah, so no problem. You can take, because a second presenter on the schedule hasn't yet joined for whatever reason. So
that is
good that you came in and...
Absolutely. Hi, everyone. Sorry I'm late. I was teaching a class and just finished. All right. Okay, hi everyone. My name is Sarah Ahmed. I am an assistant professor at Indus Valley School of Arts and Architecture in Karachi, Pakistan. I'm super excited to present my research called Piety and Polio, How Lady Health Workers Employ Islam in Polio Eradication Efforts. It's very much a work in progress. So the research that I show over here and that I have captured here is part of the larger dissertation research that I've done, in which I have in my dissertation examined women's mobility and agency in the larger polio eradication initiative in Pakistan that has been published elsewhere. So this particular data was not incorporated in that, and is very much, again, a working paper research, and any comments and suggestions will be greatly appreciated as I try to continue and form the paper into a more finalized version of itself. So this research has been funded by the American Institute of Pakistan Studies and the University of Oregon Center for the Study of Women and Society, the Graduate School, and the Sociology Department at University of Oregon, which is where I got my PhD. And then names have been changed to protect the identity of the subjects quoted here. So broadly, given that I have 10 minutes to talk about this, I want to gloss over the larger questions, but broadly
Sarah, just wanted to interrupt you. You don't have, you can take longer, because we are allowing 20-minute presentations, and we'll have questions at the end.
Oh, wonderful. Thank you.
So I'll give you a 5-minute warning around 15 minutes. Yeah. Okay.
Okay, sounds good. So broadly, my larger research questions revolve around gender development, especially in the global South. And that, again, was the larger dissertation questions and some of the publications that I've done. And so while conducting the interviews for those larger projects, in my interviews, nearly all of the lady health workers who were the prime participant group of my research were community health workers. In nearly all of my interviews, especially in focus groups, lady health workers expressed waking up early to pray Fajr, which is the morning prayer, and lots of throughout their daily routines, noting religiosity as being a part of their everyday, not ritual, but like their everyday, in their everyday lives, at work, at home, etc. And so it really got me thinking in my memos how religiosity remains a strong identity for lady health workers, and in the ways that they're employing it, why are they employing it? So some of the research observations and questions from that basic analysis of the end portion of my research was, how do lady health workers employ religiosity in everyday interactions in the home, in the community, at work? They're also unionized, so during unions, during protests. And some other questions include, how can this be contextualized given the existing socio-political and cultural norms that otherwise circumscribe women's mobility and even agency in rural spaces of Pakistan, particularly in Punjab, which is where I'm doing my research. And then finally, how can religiosity enable women to negotiate space and power in such spaces? And again, this is coming in given all of the literature that talks about existing ways that religiosity, particularly in Western academia, certain parts of Western academia might be deemed as not having much space, that religiosity or Islam, specifically in Muslim spaces for Muslim women, might not be opening up spaces and agency. So kind of like going against that kind of literature, very much in line with post-colonial narratives of Mahanti and Kabir, for those who are familiar with that literature, to kind of go against those existing problematic homogenic depictions of Muslim women being like one oppressed unit, right? So going against those kind of ideas. So my research methods, largely, I had an initial number of 30 lady health workers, and I've been able to follow up with them over the past 5 years in my follow-up interviews with 22 of those lady health workers. The work and the interviews have mostly been done in southern Punjab, particularly in the Multan area, for those who are familiar, and its suburban areas. Mostly semi-structured qualitative interviews, some focus group interviews as well. And while the primary, again, subjects were lady health workers, research participants were lady health workers, I also had some informational interviews with administrative workers who were part of the larger Pakistan public healthcare system, as well as the NGO personnel that are on the ground. And again, because I was doing so many different research projects in this one larger realm to help inform all of the different facets of that. So again, the larger research question that I was asking was pertaining to understanding women's agency in rural southern Punjab. But first, who are lady health workers? So lady health workers are female community health workers that are employed by the state of Pakistan. They provide basic door-to-door health checkups, including prenatal care and vaccinations. And they're basically the first step in the Pakistani public healthcare system, especially, and are super important, especially in rural areas where there is very low or no infrastructure or access to larger hospitals. So they will usually be the first people that will, a patient who is experiencing some kind of symptoms will go to the lady health worker. If it's something that the lady health worker with her very limited experience can figure out, that's great. Otherwise, it gets escalated to the neighborhood clinic. If that's something, again, that cannot be, that place, particularly with its expertise or lack of technology, cannot handle, then it keeps getting escalated to other levels, at a higher level, up until like a teaching hospital in, door's gonna slam, teaching hospitals in like the highest city level, right? So it keeps getting escalated up in the public healthcare system. So one of the requirements in order to be a lady health worker, aside from having at minimum an 8th grade graduation certificate, is you also need to be married, which I have all sorts of interesting things to say about, but I will keep that in the Q&A. Presently, there are between 110,000 and 150,000 lady health workers in Pakistan. The numbers may have changed a little bit because there was a recent hiring freeze that was taken off. So those numbers might have gone up a little bit more in this past 2 years particularly. And the work that the lady health workers are doing is very important, given that according to the International Labor Organization numbers in 2018, the labor force participation of women compared to men was 21.9%. And the work that specifically the lady health workers are doing is formal work, which again is very important because especially in these spaces, but also this stands for in cities as well, most women in Pakistan are engaged largely in the informal sector, where they're working without any legal protections as domestic workers, as home-based workers, as piece rate workers for the manufacturing firms. They're not really given any protection. And so the work that the lady health workers are doing by virtue of being affiliated with and being government workers themselves is very important for the visibility of the labor that women are doing, especially in rural spaces that are otherwise largely very patriarchal and confining to women's mobility and agency. Yeah, okay. So, like I said, they have to have at least a secondary school education, which is an 8th grade equivalent. Although many of the participants that I met in my research were more than qualified. Some had double master's degrees, but couldn't find jobs in the spaces they were in. This was the only kind of formal job that they could get without having to move to the cities. Many lady health workers are the first in their families to pursue education and formal employment. And so there's 15 months of training, and the training includes basic medical diagnosis skills, but it also includes social skills as well. So for example, how would a lady health worker speak to the male head of the house to get access into the home for checkups, right? Especially in spaces where existing cultural and religious norms dictate that women and men who are not related to one another should be talking to each other. So that's also sometimes part of the skill set that the lady health workers gain in their training. And this was created under the 1994 Lady Health Workers Program by the government of Pakistan. So largely, lady health workers are using social capital in the community. Moreover, the rate of, and also they're unionized, and that's really important given that the rate of unionization is also very male dominated and also very low. And again, compared to home-based workers, lady health workers are a lot more visible and mobile in their community due to the formal employment and compensation that they have. So the work that they're doing is important in many ways, but especially for like optics, for the Pakistani government, they are the frontline workers for the polio eradication program, which is very important given that Pakistan is only one of the 2 countries left, along with Afghanistan, that still has polio cases. So they're hired by the Global Polio Eradication Initiative, GPEI, which is a consortium of private, public agencies like the WHO, Rotary, some governments that are trying to eradicate polio in Afghanistan and Pakistan. So they're hired on contracts to do these polio drives. Usually are between 3 to 4 national immunization drives that that lady health workers take part in, as well as some specific state-specific drives that lady health workers are also taking part in specific areas where there is a higher rates of polio counts and polio cases. So all of that is great, but they're still maneuvering in spaces that are very patriarchal, very confining, right? And in one of my interviews, I spoke with a lady health worker and I asked her how she's able to gain access into homes where she's not related to the man who's opening the door, right? Especially when you have to go inside of the house into the annex where the children and the women are in order to specifically give polio drops. So she says, Sanya, who's a lady health worker, says, I act and talk like a man when entering someone's home for polio vaccinations. And that's great. But then, you know, as the conversation progresses, I ask her, what do you do with the money that you gain? And she says, well, my husband will spend money more wisely than I can, insinuating that the money goes to the husband when she receives it. And she's not alone in saying that. Many of the other lady health workers that I spoke with talked about how they would give the money that they earn to their in-laws in a larger, you know, a communal pot, or give them to the mother-in-law, etc. So despite talking like a man and also being part of a union that regularly challenges the state, most lady health workers are acutely aware of gendered expectations put on them and the importance for preserving a pious image of themselves in the house and in the community. And not for nothing, trigger warning, there's some headlines that showcase murder, for lack of better words, and not for nothing, lady health workers are consistently targeted in various parts of the country, but especially in places where women are usually not seen and are made as an example of what would happen, you know, and as a policing mechanism by other members in the community of what would happen if a woman would travel outside of a circumscribed social geography that is made out for them, right? So how do we make sense of this? One, again, this is gendered policing by other community members. But then on the other hand, there is also the dynamic of the lady health workers working in a Western funded initiative, specifically the polio eradication. And if you see the history, bin Laden was found through a CIA cover-up, right, which creates for some difficult, awkward, and leading to very dangerous situations for lady health workers, because they are seen not only as women that are challenging existing gender barriers, but they are also by some community members seen as being, you know, CIA, extension of like the CIA and American intervention and all of that, which again leads them again to be targeted, right? Not just in the basics. So there's a lot of intersections that are happening in this space. So when I was doing my interviews, that was sort of the context that I was understanding the religiosity and piety that was coming through. So again, when I asked if it had been hard for the lady health workers to connect with the community members initially when they go door to door and go into homes, I was told that while it was initially somewhat awkward, and in some cases they were met with resistance by women and the men to gain access into the homes, they are now usually on good terms. problems. One of the lady health workers explained to me, now the women that I meet, the patients or community members that I meet every day regard us, the lady health workers, as sisters and confide in us about their marital problems. And she said, I have even given them paragraphs of the Quran to recite for help. Again, religiosity remains as a strong identity for lady health workers. Nearly all lady health workers I met also covered their head with a dupatta, which is very much a cultural symbol of modesty, especially in lower and middle classes as well. The only exceptions I found were the lady doctors that are positioned at a higher socioeconomic status above the lady health workers and are usually also coming in from the cities. And so the lady doctors do not wear a scarf to distinguish, specifically, I think, to distinguish themselves from the lady health workers, and again, to as a way of like distinguishing on the basis of socioeconomic class. Another interesting exception was the leader of the lady health worker union, who did not wear a dupatta on her head when speaking to other lady health workers and in their place of work. But when photographed, during union negotiations or meeting government officials, she would be photographed with wearing a dupatta as well. And other things in focus group interviews as well. Whenever there were groups of more than 3 or 4, the religiosity aspect, was made very prevalent. In one-on-one interviews, perhaps it wouldn't come in as much or as frequently, but in groups of like 4 or 5 lady health workers, when I was talking to them about what they were doing every day, most of them really talked about doing that morning prayer as part of their routine, stopping frequently the work that they were doing to make sure that they were offering the prayers. So I also wonder if there's also a collective, aspect to this as well, to showcase that we are all Muslims as well when we are doing these focus group interviews as well. So findings, lady health workers cannot alienate themselves from the local culture and religious expectations put on them for various reasons. Number one, their work is tied to their reputation in the community. If they are deemed too Western or problematic, they will not be able to do their job. Number two, for safety for themselves and their children and family, right? So the reputation or honor is usually put on women to uphold, especially in rural spaces of Punjab, where honor killings occur on women for falling out of line of the expectations put on them, and usually by family members themselves. So and again, in terms of safety, lady health workers are targeted at multiple fronts. A, for being women and going outside of the house, especially in these highly patriarchal spaces, but also number two, because they are working on these foreign funded programs. And that again puts different kinds of targets on them. So number three, also, in order to do their job, they must connect with community members by showcasing that they are not there to snatch husbands, especially for female community members, or try to get women to leave their homes or westernize them, especially, when they're speaking with the male community members who is opening the door. So all of those reasons, I think, add for conscious and subconscious ways in which they are talking about religiosity, the way that they're approaching community members, the way that religiosity is also sometimes brought into the speeches of the union members as well. So is this a foolproof situation or solution? Not really. One of my informal interviews that I had with another community member talked about how she did not want to become a lady health worker. So Bushra, community member, says, I heard that a woman who used to go to people's homes to teach kids in the neighborhood Quran was raped by one of her students' older brother. Tell me, is that fair? And she was covered from head to toe with only her eyes showing. Her abaya, which is a long cloak over clothes, was so long that it would drag on the floor and get messy when she would walk around. No, why would I want to go outside if my husband makes more money for my kids and me? I'm grateful to Allah Almighty that I do not have to suffer the same unfortunate fate of other women who must leave the house, right? So even when in this particular case, if a woman is covered from head to toe, looks the part of being pious and teaches Quran, even then she is not safe from harassment, from rape, from all of these things, which still showcases women, especially in these areas, women's apprehension in order to go out of the house and do work. So I'm going to stop here. I have a few current projects and future directions that I can kind of talk about in the Q&A. but I look forward to your questions. Thank you so much.